Good morning. This is Dr. Billy Phillips, and I'm Executive Vice President for Rural and Community Health and direct the F. Marie Hall Institute for Rural and Community Health at the Texas Tech University Health Sciences Center. I'm glad to welcome you to the Telehealth at the Crossroads webinar series. We've run it all of July. As many of you know, we have had a live conference in previous years. Those have been great fun, usually at very nice locations. But we're all challenged in these times of coronavirus and COVID-19. And so because we're required to social distance and wear masks and wash our hands frequently and buildings are off limits, we decided to go to this virtual format. And actually, I think it's worked much better for us than even some aspects of the live conferences we used to hold, because we have had to put it into sort of bite-sized chunks around topics. And boy, today is going to be terrific, y'all. You'll appreciate this conference, I believe. You know, this public health emergency and all the associated waivers have driven an uptake in telehealth that none of us would have imagined a year ago. And the work of our Telehealth Resource Center has exploded as well. So we are working to keep you up to date on these changes and provide you resources to advance telehealth in your organizations and practices. We think that these will continue into at least the end of 2021, and who knows what lies ahead, but we'll go boldly into the future. I have the next slide. Now, y'all remember this is technology, so we may be a little slow. Before we get started, I'd like to provide an overview of the Telehealth Resource Center and what it does and the fine people that are involved in that on our staff. Of course, it's federally funded by HRSA to provide technical assistance, outreach, and education to advance the adoption and I would use an old term, meaningful use of telehealth resources. Just like when we were adopting electronic health records around the country, we are at that same place now with telehealth technologies. We serve all of Texas and Louisiana. We have wonderful partners in Louisiana, and we appreciate them, and I'll introduce them in a minute. And with the help of our supportive representatives, the Louisiana Office of Rural Health is key among those partners. We are one of 12 regional and 2 national facing centers that cover every state and territory that comprises the United States, including the Pacific Basin. We do have conferences and meetings and things like that, or at least we did, in that area as well. And so we get around to each other's areas, and that's an important piece of this because no one area has the same needs nor the same capabilities, but together we are a very strong force in telehealth and telemedicine. Everybody on this is highly experienced, and that includes our staff. Each of these centers has a focus area of specialty that adds dimensionality to all of us. And so we aren't just Texas and Louisiana. We can pull from any of our partners, and they're glad to work with us. So we welcome our speakers and attendees today to the Crossroads Conference. A few housekeeping things that I'll mention. If you want to ask questions, use the Q&A feature in this Zoom meeting. And this session is being recorded and will be available on the TRC website. If you miss it or have to leave early or you have technology issues, you can circle back to that. So today, the webinar will demonstrate how 2 health systems in our regions ramped up telemedicine, starting with the programs already in place and then rapidly responding to the COVID pandemic. With Ochsner Health System, more than 20 years of healthcare experience, and April Radford currently serves as the Vice President of Ochsner's Care Connect 360 Telemedicine Division. She earned her Bachelor's of Science in ophthalmic medical technology from LSU Medical Center in 1998. And she must have been about 10, April, I don't know. Anyway, and her master's in business administration from the University of Phoenix in 2008. She is a certified medical practice executive, a certified mentor, and has been employed with the Ochsner Health System since 1999. With Parkland Health and Hospital System, I'm glad that Mary, we call her Molly, Case is with us. She's an 18-year veteran of the Parkland Health and Hospital System. She began her career as a patient care technician in general surgery and transferred to the National Intensive Care Unit after graduating nursing school. She has held various positions within the organization, including working on the electronic medical record adoption, the go-live management, government waivers, and process improvement that we all as regional resource centers adhered to and helped our clients adhere to. She's been a director for the virtual care department for a year, and Molly has a Bachelor's of Science in Nursing from Texas Women's University and a Master's in Healthcare Administration from Ohio University. She grew up in a small town in East Texas, is married, and has an energetic 9-year-old. She enjoys cheering on the Dallas Mavericks and the Texas Rangers. And boy, do I hope we get to see them live again real soon. Any rate, it's my pleasure to turn it over to April Radner to learn more about how Ochsner has responded to the pandemic. And then Molly will take over from Parkland. You all are in for a treat. This is going to be a great presentation. We'll have time for question and answers at the end. So without further ado, I will turn it over to you, April.
Great. Thanks, Dr. Phillips. I really appreciate you having us today. Eager to share our story. I think we all have a lot to learn from each other, so we're happy to share our lessons learned throughout the COVID ramp up. I wanted to just start a little bit and say that, the pandemic conditions were really ripe for telehealth adoption. There's some history that, we see patients who are still learning what telehealth is about, what virtual visits are. There's still a lot of language, even, when we were pre-COVID about, what those allowances should look like, not only at the state levels, but also at the national levels. And so when COVID came, this crisis created, in some respects, opportunity really for telehealth adoption. We saw the government expand in many areas, allowing for, different technology uses, different video platforms, FaceTime, Skype, all of the Doximity, many of the video platforms became, all in for doing telehealth, which really made it a lot easier for patients and providers to connect. We saw also a rapid expansion of emergency licensures across states, where the states were saying, we'll grant some telemedicine licensure, and then we saw, CMS and other payers really come to the table to say, we're going to go ahead and cover this effort. And so with all of those flexibilities now in place, it really allowed a rapid adoption on both the provider and the patient side to move very, very quickly into telehealth. And so I'll share a little bit of how where we are before COVID started, so that you get a good feel for how we responded during COVID. We actually have a long history in telemedicine. It mostly started with a store and forward program in 1998 with pediatric echocardiograms, and then we moved very, very quickly into telestroke. As you know, this is the way that most organizations actually get their start in telemedicine, because there's such a great need for care across all of the rural communities when it comes to vascular stroke and dealing with patients in their own facilities. And so we moved along those tracks and began developing other hospital-based solutions. And the reasons for those starts is because those were the obvious places that we could serve other organizations, that we could serve communities, that we could serve patients, but also there was a reimbursement structure, there was an allowance structure that allowed us to do those things. And so you move a little bit further on into the 2018, 2019 arena, and that's when we began working on our direct-to-consumer platform. And this is a way for providers to connect directly to patients. And while we were a little bit ahead of where a lot of the payers and CMS were in covering this, we very much thought that we needed to be part of the digital transformation that was taking hold of the healthcare industry, and create some opportunities for patients to be able to connect with us faster and more conveniently. And so that's where we started to get some of our experience in direct to consumer. So all this to say that we have platforms kind of across all the delivery channels, which really kind of set us up for our most success when the pandemic began and the crisis started, and we had to get moving very, very quickly. So in essence, we're becoming a full comprehensive health system that offers all telemedicine services. These are just some examples of what we've done over the year and some of the accomplishments that we made. We're very much in the interest of learning how to serve our rural partners, the rural health systems, our patients better. And so in some ways, we're becoming a little bit of a solution center as well to help guide and and sometimes even supply with the equipment and the platforms that are needed to deliver care. And so we're really excited about being able to share this information with you today. This is what we look like in partnerships. So we've done a lot of work to build relationships with other health facilities, employers, to be able to deliver and bring health services across Louisiana, Mississippi, and now stretching definitely into Alabama. And so this is all what pre-COVID looks like, right? So now let's really get to the meat of why we're here. We used all of these channels to be able to serve others very, very quickly. What we did was we quickly ramped up some urgent care clinics with some virtual tools there that would allow our providers to get to more places faster. We trained actually more than 2,400 auctioneer and community providers to launch into virtual care so that they could stay connected with their patients. We deployed hundreds of pieces of equipment so that all the entities could stay in touch. And I think one story that I like to highlight a little bit too is the ingenuity that came out of our nursing staff in the fact that, we've got COVID conditions now. We're trying to reduce the utilization of PPE as much as we can and be diligent about making sure those supplies last. We're wanting to make sure that we're reducing exposure both for patients and providers. And so all of us experienced some reduction in the ability for visitors to come into our facilities. And so what that created for families and their loved ones that were in the hospital was fear, right? There was no way for them to interact, to understand. And so our nursing staff and our provider staff quickly learned that they had to stay in touch with the family on the outside because they weren't here in the facility with us. And so we've called it a Family Connect program, where our nursing staff and our provider staff actually did video, audio interactions with the families outside of the health system. And because they were on very mobile devices, they could also then go in the room and create the connectivity between the patient who is in the bed and the family on the outside. This brought about great peace of mind for our communities. We have a lot of great stories that came out of it, and while in the patient's cases, there weren't always happy endings. There was an opportunity for a loved one to be with them through those final hours, and so that brings a great comfort to our communities. So where I wanted to focus the work, though, is really what we did with our direct-to-consumer service and how we used virtual to really provide care to patients, not only in a direct-to-consumer virtual action, but how we brought that virtual interaction and we kind of navigated it with our health facilities to create this holistic way of managing COVID for our organization. Again, trying to reduce exposure, also trying to be there for our patients, also trying to, continue to serve patients with providers as quickly and as rapidly as we could, with, the key provider, our key urgent care providers. So Ochsner Anywhere Care is a platform that we have that's powered by American Well. It's staffed by our Ochsner urgent care providers. This is really an audio visual interaction. We also have what we call an Ochsner Health Kit powered by Tyto that you'll see down in the bottom left-hand corner of your screen there, that really allows for some diagnostic interactions during the virtual visit. And then on the very tail end, we had also partnered with a local company to help do delivery services for pharmacy. So if you're located within 30 miles of one of our Ochsner pharmacies, we can do free prescription delivery. So in essence, this has really changed urgent care even before COVID. But as we look to respond to COVID, we had to get a little bit more creative about it not just being virtual, because we know we still had patients showing up in our urgent cares. And so that interoperability and that seamless navigation and transition between virtual and in-person was critically important. We had to learn very, very quickly how to make those work and coordinate care, including even the setting up of testing sites, as our labs were able to increase their ability to do lab testing for COVID. And so I think that's the skill set and the lesson learned is that, virtual care is it's not something totally different from our health system. It needs to be part of a coordinated care effort and a way to serve the patient holistically and in a way that our patients and our providers can navigate those virtual and in-person interactions very, very well. So you can see here, urgent care combined with a virtual serving combined with our virtual diagnostic tools, and our testing drive-through really kind of gave us this frontline offense for being able to serve patients, making sure they could stay in the facilities or at home in the locations where they were comfortable, still have easy access and the ability to interact with a provider, even in the event that they just needed to know what to do, right? Because there were still a lot of questions at the time about, do I have COVID? Do I need to get tested? And so this was a way for us to do some early screening and triaging as well. So during COVID, we've got another timeline, right? Prior to COVID, we've only done 556 direct-to-consumer visits. When you get well beyond, and I'll even give you the number for today, we're at more than 170,000 virtual visits to date. And that really was the coordination of one, putting virtual clinics with our Tyto devices into our urgent cares that allow patients and providers to have a full diagnostic, see throat, see ears, and still do an interaction, allowing our providers to get to as many facilities as they could with the ability to tele into those locations, increasing and training the number of providers that we had on staff to be able to deliver telemedicine, and then continuing to move on with service in those areas. So as a result of that, Louisiana had the peak of its COVID during the month of April. And you can see here on the right side of the screen where it says, the weeks of August 8th and August 15th were our peaks. This also represents what we looked like green being our in-person visits, orange being the number of virtual visits that we did. Our virtual response was critical to staying connected with patients, not only through urgent care, but also through our specialties in primary care. For example, oncology came to the table. They saw their patients virtually. Rheumatology, neurology, every specialty that we had was interacting with their patients through virtual. And we really believe that this is the way that we kept, one, our organization whole, but we kept in touch with our patients and gave them the care that they needed and they required during this time where it wasn't safe to get out, it wasn't safe, or the perspective was it wasn't safe to get out and travel. And so we think there was a tremendous response. We're very excited. I wanted to just dig in a little bit deeper. It'll only be a few more minutes here. So this is our Auctioner Anywhere Care platform. This shows basically the virtual visit volumes and how you see the peak during our hot months and then some tailing off as we go into the future. Pre-COVID on the left-hand side of your screen shows where we were serving patients, relative. And just keep in mind, we have a health system, a major health facility located in New Orleans, Baton Rouge, Lafayette. We have some partnerships that extend throughout the states here. And yet this is what we look like. We're still kind of serving pretty much close to home. Post-COVID, we start to see that expand quite a bit, and we're able to interact with patients in more locations. You start to see us actually even begin to penetrate a little bit deeper into Mississippi across the Gulf Coast there. And what we know about that area is that there are not a lot of primary care physicians, and so we were still able to provide care. What we also noticed is that we had a group of patients who, while they were Louisiana residents, moved out into other areas. They had to go attend to other family members, so they were moving into other states. We still had an opportunity to interact and serve them. This is what we do in our MyAuctioner. You guys might know that we have Epic as our electronic medical record, and they have telehealth solutions built within. So this is what we call MyAuctioner. These are our clinic visits volumes. You can see that, in the week of April 20th, we're getting up to more than 15,000 virtual visits per week. But you can start to see the saturation change, right? And this is just really representative that the patients and providers really began to embrace the use of virtual care throughout this time. So here are some more interesting data points that I wanted to share with you. Pre-COVID, we were most of the population that we were serving was white or Caucasian. We had some opportunity to serve our Black, African American, Latino, and Asian communities, and yet we saw that change also during COVID, and that they were engaging those populations were engaging more with telehealth, and that's really good for us. We'll want to continue to understand what the barriers are to access to telehealth and continue to remove those so that everyone can have access to care that's convenient throughout, not only COVID, but ongoing and forward. This is just a little bit representative of, what happened with the MyAuctioner appointments. The same story that continues to improve, and we can serve more patients in more communities. So we're really excited. I wanted to share also a couple more points. There's on how this environment created opportunities for our Medicaid and our Medicare population. And I know not everybody's brave enough to show these numbers, but I really wanted to show how this changed for our organization. Prior to COVID, we did not see a whole lot of our Medicaid patients interacting with us virtually. And yet when the environment shifted, we really started to see that change quite a bit. What's so great about this is that as CMS and the other payers came to the table for saying that they were approving coverage and reimbursement, I think is when those patients began to see less of an out-of-pocket burden or an avoidance of using telehealth, and they could still stay connected to care. So this is a representation on what happened and how the heat map changed for us with our Medicare population. Also very remarkable. We know that this is also one of the more delicate populations that we serve, and so staying connected throughout a pandemic is really important for that group as well. And then our commercial payers, they honestly didn't change very much. I think that's because we have some parity in Louisiana, and they were already at the table covering telehealth benefits for their insured population, but wanted to just show this for you in comparison. So with that, I will go ahead and just pause for some questions. I know that was a lot of information. See if I can pull up.
So one of our folks on the webinar has mentioned that early steps providers are struggling with CAT members, and if whoever that's coming from, it looks like Kelly Stone. Kelly, that's a Medicaid program for you all that may not know. Kelly, you want to talk about that a minute or ask a question about that? Oh, the patients are not comfortable. Okay. Isn't it always that way? You have a cultural lag period for providers who use this technology, and also one that patients often have to adapt to it as well. We don't often think about that. We think mostly about providers, but it's a two-way street, isn't it? So here's if I might, April, ask this question. These are dramatic shifts in what you've done pre-COVID, post-COVID. And I'm curious, would you like to sort of speculate for a moment about what you think will persist once we get past this particular moment in our history?
I would. I think that telehealth is here to stay. I think we're all trying to learn what are the best patterns that allow this to be sticky with our patients and our providers. I think I know actually that there are conversations at the national and the local state levels about, how do we continue to appreciate the flexibilities that we've had throughout our crisis and emergency declarations and really start to hardwire and create some permanency to this. I think a lot of the health systems are coming together to say, look at the data that we can show that we've touched more lives during this through virtual. This should be the way that we can have another tool in our tool chest to be able to connect with patients, to also be able to share and connect with other health facilities as we see shortages in some of our specialists and our providers, and an opportunity to say, this is just another mechanism for care delivery that we have that becomes easy, accessible, convenient, and affordable for patients and providers as well. So I think you're gonna see this stay, and I think we're gonna begin to dive into some definitions about and better understand, low acuity versus high acuity, and where that line comes in on these things truly are appropriate for virtual care, and there's still going to be quite a bit of opportunities to serve patients in person, and that's appropriate as well.
Very good. As we pause here, those of you who are looking for platforms, let me encourage you. We have a terrific TRC staff, and I meant to thank them earlier. Dr. Ariel Santos, a wonderful surgeon and a fine colleague, is the PI for our TRC grant. And Cameron Ox is director of the division in the Institute that supports all technology and particularly telehealth. Kelly Munoz and Becky Bounds are a dynamic duo who do outreach and education for us. And our particular specialty is working on how you get paid for this. So thank you all on our team. You all are terrific. Dr. Santos and Cameron, Kelly, and Becky, I can't say enough good things about you. All of you in the webinar today, reach to those folks if you have questions. And I'm seeing some pretty interesting ones down in the chat that can be answered and probably helped by this great group of people. All right, I think it's time for Molly. Molly, welcome. It looks like you're up for a few minutes to talk about the programs at UT Southwestern. Parkland, sorry.
That's okay. We run along together. But thank you, Dr. Phillips, and thank you, everyone, for entertaining me here today. So straightaways and curbs, I picked that as the title for this. And you may be sitting there thinking, you know, what is this lady talking about? Straightaways and curbs. And I promise I will not have a lot of sports analogies in this presentation. However, this concept kept coming back to me when I was writing this presentation. Many of you, I know I've said it, the COVID response has been said to be a marathon and not a sprint. And as I sat back and really thought about that, and while it is true, I also felt like there's a level of conditioning that is occurring for us, for everyone who's taking care of anything that is virtual care, telemedicine or telehealth initiatives. And so straightaways and curves was a conditioning technique that my high school track coach actually used for any kind of distance runner. Whether it was marathon type running or sprinting, and you would actually sprint the straightaways and then you would walk the curves. So you would have this time where you were going all out, putting everything you've got into something, and then taking a moment to recover. And while maybe recovery is not quite the word that I would use for COVID, with regards to the curves in this, what I would say is it is a time to reflect and look at what it was that was done. What did I just sprint and do? Okay, now this is what I've done. Is there anything I need to optimize? So that being said, that's kind of the method that I've used to set up my presentation today. And we'll take a look at what Parkland was doing prior to COVID. So in our virtual department, we had existing programs. Parkland Connect being what eventually will be the flagship that a lot of things are set upon here at the organization. So it's an acute care, it's direct to consumer, and it's utilizing our providers. We expanded this to include community access points. And I'm not going to talk a whole lot about those now because that's what I'm going to really focus in on in the next slide. And then again, when I go into the COVID response piece, those are the community access points, or CAPs, if you will, are something that we were extremely excited about. Virtual encounters, which typically here at Parkland were telephone encounters that were requested by the patient. They're through our community-oriented primary care clinics. And so those are all Parkland clinics, and we have 12 of those. E-consults, youth and family, which is based out of schools. Behavioral health in our emergency department was one that we have seen an increased growth in. Trauma behavioral health follow-up, as well as some post-discharge pharmacy and virtual shared medical appointments. So all of these are the programs that we had already established prior to COVID arriving. And so as we move forward, I want to talk about this CAP expansion piece just a little bit. So the community access points. There are areas within the communities that Parkland cares for within Dallas County that really have restricted technology resources. Whether that be they don't have broadband access, they can't get a cell signal in these areas. They're absolutely dead zones in Dallas County. Or maybe our population, this particular individual just doesn't have the plan, the cell phone plan to help cover video encounters. So we wanted to be able to provide the opportunity for video for everyone. So we really reached out and we started looking at different areas where we could establish. So you see Jubilee Park here. We also looked at community centers, libraries, community colleges, food pantries, etc. So we have a lot of community partners that you see to be a part of these CAPs, and I took it literally here. You know, and we were looking at some Bonton Farms, Dallas College, public libraries, and to that nature. One of the big things to please notice is Jubilee Park here. We established this and launched at Jubilee Park, which is a community center. They provide all kinds of resources to the community that surrounds it. They also provide some housing for individuals, and they are utilized to really almost the nth degree. They're looking to expand their breadth in that area because they're just utilized so much by the community members. We went back and made some optimizations. So we relaunched this CAP on March 9th. That's an important date to keep in mind. And I'll go back and talk about it here in a little bit. But that's the concept behind the CAPs, was trying to reach people in areas that they're already utilizing, but providing the care that we can provide. So how were we performing? Parkland Connect, and don't be put off by the numbers. This is something that we were still trying to get buy-in from the organization. You know, you can see that the overall volumes were low. We do monitor this based on video and virtual. And in this definition, virtual in both of these graphs equals phone. And, you know, we want to be able to provide that as an option. We weren't wanting to mandate video, and that was important to us because we know we have those gaps in technology. What you see with the numbers right here in December, they jump up. We got some buy-in from the organization. We were able to put a full-time provider on there. So right now this program is run by one provider. The drop off in February, I will explain, she was out for a week with the flu and then had a week of vacation. So in an already short month, it was even shorter. For our population health virtual visits, these are the ones in our 12 COPCs that we have. And the patients actually are reaching out to the clinic and requesting this. So this is not something that we were driving. This was something that they were driving. And these were all done telephonically. So just an overview from our organization and then virtual care for our responses. The organization, we had an incident command center. It was set up and it's still set up at this time. We did establish a drive-through testing site for Parkland patients, first responders, and essential workers, and that was here on campus. We've staffed and operated large-scale county testing sites. One of those is still operational, and that was, you know, in conjunction with Dallas County. And we created and designed specific COVID-19 units and, well, wards. So virtual care-wise, we created, and this was an internal solution that we created, was a mobile observation and logistical information machine, the Molly machine. And I promise I'm not so egotistical that I named it after myself. Somebody did that, and you'll see a picture of it here in a moment, and you'll understand why maybe the flattery is not completely there. But it was something that was developed for a crisis response. And so for that, I am very proud of it. Integrated telemedicine carts. And so these are the big pretty ones everyone thinks about, you know, has a nice screen, has the peripherals that are attached to it. Integrated in-room video chat. So April had spoken about the Family Connect concept that they have at Ochsner. And this is something that's very similar to that. Our IT team built a server during the middle of COVID because they had nothing else to do, I'm sure. And so they built a server out for us, and it allowed us to have the patients utilize the foot wall. So we have these TVs at the base of the bed, and it allowed them to utilize that to do a video connection to family and friends that they could then see in a larger picture. And so this has been a really exciting move for us in allowing for that to occur. Back to e-consults, we had an infectious disease e-consult that we did develop. That was an inpatient e-consult. We had not previously done inpatient e-consults. And what the ID providers were finding is that there were a lot of hallway discussions. Well, what about this on my patient? They really wanted something that they could have, that they could keep track of these patients that they were assisting providers with their questions on. And so the e-consult came up, and that has been one that they very much appreciated. iPad solution for neonatal ICU and COVID positive moms. Of course, this one was near and dear to my heart as a former neonatal nurse. But the moms can't go into the NICU, and they were in COVID wards. And so we provided them a way to be able to have that interaction. It was an iPad solution, very basic, but it allowed the nurse in the NICU to call that mom when they go to provide care to the baby, so the mom could see the baby and see the care being provided. And if the mom needed to reach out at any other time, then they could look to get that, successfully implemented. Rapid expansion of existing virtual encounters. So again, April talks a little bit about this, or what this looked like for their healthcare system. And for us, we had been in those 12 clinics with just that set of providers. We very rapidly, probably within a week and a half to 2 weeks, pushed this out to all of our specialty clinics, as well as our pediatric providers. And then eventually rolled it on out to radiology and anesthesia and some of the other, even more specialized services. With that, of course, there was continued optimization, I will say, with regards to our documentation and things to that nature. But we got that rolled out, like I said, within a week and a half to 2 weeks. And that proves to be, it was a huge undertaking. We had one of our providers did all of the education on this. And so I probably owe her dinner when all of the dust settles on COVID. Establishment of a standardized video solution for outpatient encounters. That also, so of course with the 1135 waiver, oh yes, go use whatever video solution that you want to use. We don't care. We won't penalize you. Well, that's kind of a problem for a healthcare organization. And we did not have anything established yet in the outpatient areas for our COPCs or OPCs. And so we've been working diligently, and we're getting ready to finally launch the pilot. We have our integrated platform piece that's working with that, so that we can continue to move forward with videos as we need to, but in a standardized format. We did allow for the use of Doximity, Skype for Business, and WebEx, but we did ask them to please not use Zoom. We didn't need anyone being Zoom bombed during the middle of a patient interaction. Oh, let's see. So the ramp up, the planning prior to the arrival, these are some of the lessons learned and what we were doing in real time. So prior to the arrival, our incident command center was actually up in early February, and COVID did not arrive in Dallas until really the second full week of March. It arrived in Collin County, which is just north of us, a little bit earlier than Dallas proper. But so we already had some of the bones of the organization working. Working in parallels was extremely important during what we were doing. And so we were able to quickly devise a solution, which this is a picture of the Molly machine. You see why maybe flattery isn't the best, except for the tall, skinny thing I would take any day. But this is an example of one of the Molly machines. And we were able to come up with this while also looking for that other solution that was the pretty telehealth cart. And if we've not done both simultaneously, we would have been in a lot of trouble as we started to see more COVID patients come in. We were able to develop a COVID ward in conjunction with our facilities team and our surgical team. so that everyone was in the same area, but it was a non-traditional patient space. And so the Molly machines would have needed to have been plugged into Ethernet ports and things of that nature. You don't have those in spaces where you're not intending to have patients. So by doing both in parallel, we were able to have both solutions ready as we needed them. And then multidisciplinary discussions during the ramp up was something that we really had to focus in on, making sure that everyone was at the table. Nursing, HIM, finance, informatics, everyone at the table so that we could have the conversations and keep and prevent from having to do any of the modifications or gap filling after something had already been accomplished. So the current impact, this is Parkland Connect. Here is where we finished off the first quarter and a half, and then here's March. And then you see us ramp up. April, we were experiencing a peak. We turned it down a little bit, not surprising as we opened up in May a little bit. I'm interested to see what our July numbers do because, of course, if you've been watching any part of the news, we shot past everything that we did in April in the month of July. So I'm interested to see what our numbers do both for Parkland Connect and population health. The other thing I want to mention on this graph is you notice that the number of video encounters increased. And so what we did with our Parkland Connect program is in March, we had hired in a customer service rep. And she is dedicated to Parkland Connect. She was training, God bless her, in the month of March, new to the system, new to healthcare, and welcome to COVID. And so she got trained up, and in April, you can see the impact this started to have. Now, what I haven't had time to do really is to sit down and see if when this dropped off in May and June, if that was just because they were requesting phone or whether that was a conversion where they couldn't get the video to work on their device. That's just going to take me some time to sit down and really be able to analyze. And then our population health visits, you can see we had quite a jump. And of course, we were doing all of our education for our providers. And then in April, of course, we were hitting our peaks. And for some of these weeks in through April and even in May, even though you see the drop off, and that had to do with the opening of Texas and we started seeing more patients in person, we were experiencing approximately 70% of our patient volume was being seen virtually. And so that's outstanding. And also of note, our no-show rate dropped dramatically, which was also something that was a fantastic aside for what we were seeing with the virtual encounters. We were able to get them at the place where they were. Transportation in Dallas for a lot of our patient populations, it's not a one-way street where you're just running right down the road. There's multiple public transportation jumps that you have to make, 3 bus rides, a bus and a train, and a walk 2 blocks down the street, something to that nature. It takes 2 hours in some cases to get where they're trying to get to. So we were very excited to see this. So the overall lessons learned for us were, of course, working in parallels, taking time to reflect and review what it was we implemented. Just taking that curve, taking that time in the time, because otherwise you're going to have a little bit of a mess to go back and clean up later. Don't overlook the obvious or basic solutions. Sometimes, especially in crisis, those are the best ones you can go out and do. Maybe there's an end game and some different phases that you would like to do along the way, or maybe once the response is over, you would want to go that way. But you don't want to overlook what's just right there in front of your face. Seeking performance and request feedback on those that you put up. The feedback piece is huge, and it's something that we've got to go back and do multiple times. You can't always get the feedback in the here and now. And so following up with those, the provider staff, the patients, whoever it is where the focus was, and anyone that's ancillary to those processes is an important part, so that you can determine whether or not that's something worth keeping down the line. Recognizing the constraints without underestimating or overestimating really the customer. Really, this comes down to communication and conversations. Talk to people. Don't assume anything. We know that we have technology constraints for our patient population. That's not an underestimation. That's a known. But I also, and I will say this directly about the Molly machines. I really was concerned when we were rolling them out to the floors. We were rolling them out amongst, a crisis situation. How is the staff going to take this? This is just one more thing on their plate they have not had to deal with. They haven't had to do anything with. And here I am putting it out there. I severely underestimated that. Nurses who, as a nurse, I was really most concerned about, because they're the ones in the rooms most often. They loved them when we rolled them out. It provided them that additional barrier, that additional piece that they felt like really helped them provide a higher level of care. And I severely underestimated it, and I'm glad that I pushed it anyway. Incorporate virtual opportunities into essential businesses. This is such a key to everything. And if there was one lesson I learned from and have learned from COVID, is the word essential. The word essential. And so I'm going to come back to our caps. I promised that they would come back. I said we relaunched Jubilee Park on March 9th. And the very next week is when I got a vocabulary lesson from Judge Clay Jenkins, and that was essential businesses. And essential businesses was not a part of the consideration when we were looking at doing these caps. We knew that we needed to get into the community. Well, this is what happens when there's a shelter-in-place order. The last one was a punch to the gut. And right when we really needed it, it was closed. Now, if I had to go back and do it without the knowledge, with the same knowledge I had previously, I would have done that anyway. So I don't second guess what we did. But man, that's a lesson that I will take going forward, because it's completely shifted my line of thinking as to where we need to ensure that we have more of these. So the race is on. I'm going to come back to my sports analogies. So there's so many questions. What will we keep? What will we sunset as we move through? What's moving forward? How do we pick those up that we left behind? My poor youth and family, the schools closed. I don't even, haven't thought about them too much. How do I bring them back into these conversations as we're picking up the pieces? One of the things that I'm constantly reminding myself is to pace myself. Don't let everything around me dictate what I'm doing. Make the strategic decisions. Make sure that you're positioning your organization for the greatest impact for the customers as well as the organization, and maintain that multidisciplinary communication, because otherwise something large is going to get missed. Basically, in conclusion, the straightaways and the curves are a conditioning technique. Conditioning for what? This marathon that we're already in. Are we really already in the marathon? I honestly think that at some point we're going to look back and COVID's going to be a blip of time. It was here, wreaked havoc, and now we found a way to move on past it. But it's prepared us for the real race, the one that's coming, and we might as well compare it to the Olympics. It's an Olympic year. We're missing out on them. This is the Olympic marathon that we're getting ready to run. The Pandora's box has been opened. Telehealth, telemedicine's out there. We're about to have to push through so that we can cement the opportunities that we've put in place during COVID, so that those are permanent solutions for the future while we also continue to grow. So I would argue that while we've been running a marathon, we've also been conditioning, and the real race is about to begin. And so in the end, who wins this race? the patients, obviously, communities, the healthcare organizations, the payers will when they finally buy into what we're doing. So in short, everyone does. So thank you. And Dr. Phillips, I will hand the mic virtually back to you.
Thank you, Molly. That was wonderful. And also, I want to again thank April. What a great presentation you two did. And so this is a time to open up for questions. If you have questions, Kelly can unmute your mic so you can pose them to our speakers. Give her a moment or two because it's, again, technology. So floor's open for some comments or questions. I have some that I'll save for the end. Monitoring the chat, there's been some wonderful conversation about we're all on a learning curve. The marathon rather than the sprint. Dr. Santos made a great point about finding the pain points for our patients. Relates earlier to the comment about the acceptability of this mode of delivery of care. And that's a very good point. We also have a good point about early detection and prevention applications, less white coat nerves. Thank you for that, Kelly Stone. And Cameron Ox makes the point that both of your organizations have implemented a number of solutions during this COVID pandemic. And he would like to know more about the administrative barriers that you encountered, contracting, legal compliance, reimbursement, and so forth. So that's a little synopsis of what I see in the chat. Any comments from our speakers or our audience?
So I can speak a little bit to Cameron Onk's question regarding the administrative barriers. So when I was talking about having everyone at the table, compliance, legal, 100% need them there. Finance was always at the table with us. You know, the barriers that we experienced were really more in the way of the moving waivers, the additional information that would come. So we would have our meetings, we would make our decision, we would know our pathways, and because these entities were always at the table, the conversation was always up front and just immediately out there. However, then you turn around and all of a sudden now, which made sense and still makes sense at this time, telephone encounters are the same as face-to-face. Well, now we got to go back and have this whole conversation again. And so for us at Parkland, at least, the barrier wasn't so much with those departments coming up with, you know, either providing a barrier or a block to what we were trying to do, as much as trying to stay on top of what the ever changing legislation and guidance on these things were at that time.
Molly, I think those are great points. Those are the same experiences that we had. We were all hands on deck, and it absolutely takes more than your IS team, more than your telemedicine team, more than your clinical partners to make sure that you can build these telehealth programs and also do it at a rapid pace when you're responding to a crisis. So it's everybody has to be all hands on deck. Everybody has to bring their A game. We all have to be scanning the environment for language and changes that we can take and quickly, you know, assimilate. Like you, we were busy keeping our eye on all of the new language coming out from the payers from each state. You know, collaborating with our legal partners to make sure that we understood, you know, if we have established patients that have relocated themselves to another state, Is it okay for us to see them in that state? And can we do that by audio, or can we do that by video? Is it required to do that by video? And I think, I think what we're learning is that it takes a whole, what do we say about raising kids? It takes a community to do that, right? It takes a community to raise these telehealth programs. And so the lessons learned for our organization is that, it's not telemedicine's responsibility to build the program. It's all hands on deck to be able to build good programs in a normal state. And then especially during COVID, having a rhythm for communication and quick adoption of all the new language. We had what we call the Telehealth Reimbursement Committee in place before, as we were seeking to understand, how do we build the right way to bill payers? How do we build the programs? It has our compliance team, it has our marketing team, it has telehealth team, our contracting team. And so we got together monthly to discuss, new things in telehealth, and it became a weekly rhythm for that group, starting in March when new language and new waivers started to come out. And so setting up that infrastructure and those collaboration times is really, really important, so that you can hit the accelerator or pump the brakes when it's, not necessary to be in contact that frequently. So it all boils down to infrastructure, I think.
Thank you, April. I'm Becky Bounds, that Dr. Phillips mentioned. I want to just talk to you a little bit about the slide you're seeing now. On the left are all of the webinars that we had through July. They will all be available. The recorded version will all be available on our website, texlatrc.org. And wanting to let you know that we are working to keep you up to date and give you the information you need during these challenging times. We have virtual office hours currently twice a month. See our website for that. Telemedicine for 101 for those just starting telehealth. And then the National Consortium of Telehealth Resource Centers has a webinar series that's generally on the third Thursday of the month. So check our website and the National Telehealth Resource Center site. And here are some, for more information, if you want to contact us, here's an email address, our website, and then telehealthresourcecenter.org is the site for the National Consortium of Telehealth Resource Centers that will also lead you to whichever resource center in whatever region you have interest in.
Very good information. I want to thank our panelists, April Ratford and Molly Case, for excellent presentations. Thank you all for the chat questions. We kind of tried to monitor those, and they've been great. We're a little past our scheduled time. I want to thank our team again, Dr. Santos, Mr. Ox, Becky Bounds, and Kelly Munoz. Y'all are terrific. Dr. Santos, do you have any closing comments that you'd like to make, sir?
No, this is actually an excellent presentation. Thank you very much, April and Molly. I enjoyed today's presentation. I would like to congratulate Oxnard Health and Parkland in doing an excellent job in providing virtual care to Americans in Louisiana, Mississippi, Alabama, and Texas. And appreciate your ingenuity, and indeed the pandemic hastened and catalyzed the adoption of telemedicine. I appreciate your stories and sharing your experience. I'm pretty sure all our attendees have, something that they could pick up and found very helpful with your experiences. Thank you very much, Dr. Phillips, as well.
Thank you. Well, thank you all. I hope you all have a wonderful day. Stay safe out there, and follow your masking, social distancing, and hand washing, and trust in the rest of it will be just fine. Thanks again for joining us for the TxLA Telehealth Resource Center Telehealth at the Crossroads presentation for today. We'll wish you goodbyes and a good afternoon. Thank you.